Welcome to all of you who are joining us. We'll give folks another minute or two to join, and we'll get started. Thanks for coming tonight. Great. In the interest of time, I'll get started on introductions and a little housekeeping. So my name is Larissa Williams. I'm an associate professor of biology. I'm also the incoming chair of biology. I am so thrilled tonight to host Lou Weinstein, Dr. Lou Weinstein, who is a Bates alum, to talk about COVID-19 vaccines today. So we are like the COVID Cafe that I hosted at Bates this past year. We actually had 8 of them. We are going to focus on medicine and science tonight. And if you have questions that you haven't pre-submitted, we would love to have them in our Q&A box, which is on the bottom right screen. And I will be fielding those questions tonight. So I'm going to introduce Lou, and then Lou has a set of slides to share with you about sort of what we know about the vaccines to date, and then we'll open it up for questions. So for those of you who don't know Lou, he was born in Cambridge, Mass, and received his undergrad degree in chemistry from Bates. Following med school at Wake Forest in North Carolina, he completed his residency in obstetrics and gynecology at the University of Colorado, and actually served as a lieutenant commander in the US Navy and completed a fellowship in maternal fetal medicine at the University of Arizona. He was then on the faculty at the University of Arizona and rose in the academic rank to full professor, served as a director of divisions of both maternal fetal medicine and research, and was recognized for discovering and naming HELP, which means hemolysis, elevated liver enzymes, low platelets syndrome in 1982. And to date myself, I was a 1983 baby, Lou. He later served as a professor and chair of OBGYN at the University of Toledo School of Medicine in Ohio, and as Boward's professor and chair of OBGYN at the Sidney Kimmel College of Medicine at the Thomas Jefferson University in Pennsylvania. In 2011, Lou moved to Charleston, South Carolina, where he became director of the Women's Services for the Barrier Island Free Medical Clinic, which serves the region's uninsured patients. He has recently been appointed to the board of directors of Volunteers in Medicine America. He's on the Alum Council for Bates and the Medical Alumni Association for Wake Forest University School of Medicine. So welcome. We're so excited to hear the latest and greatest about the COVID-19 vaccines, and then start fielding some questions. So welcome everyone, and we're so excited to have you here tonight. Go for it, Lou.
Dr. Williams, thank you very much. Let me go ahead and share my screen and we'll get started. Give me half a second here and we'll get on slideshow. There we go. I really appreciate the opportunity to speak with you tonight. My whole career has been in academic medicine, except for when I was in the military. And I'm predominantly a researcher, an educator, and a clinician. But what I enjoy most is teaching and taking care of patients. And I've done that for my whole career, and hopefully will continue to do that for a long period of time. And what I'm going to talk to you tonight about is the importance of understanding the COVID vaccines. There's so much misinformation and good information about the vaccines, and I want to share with you what is available. And I will tell you that I've updated everything as of 3 o'clock today. So you're seeing the best numbers I could possibly get for most anything. Full disclosure, I'm not speaking for Bates College at all. I'm not speaking for the American Medical Association, although I am an officer on the governing council. I'm speaking for myself as a clinician, as a physician, and as one who desperately cares for all patients, especially the underinsured and uninsured, underrepresented minorities. I like to start with quotes. Almost every time I give a talk, I use a quote. This is one that's obviously predates all of us, and it is circumstances and proper timing that give an action its character and make it either good or bad. And if there was ever an unusual set of circumstances and unusual timing it has been the year of 2020 and 2021, both for all of our citizens of the United States and for all of us in medicine. None of us have ever seen anything like this, and hopefully we never will again, but unfortunately, I think this is just the start of what may be pandemics in the future. Remember the 3 Ws. That is really the key. And when you look at 2020, we had the lowest influenza rate in the last 3 decades. Why did we have such a great influenza season or a low influenza season? Because we're doing all the things to prevent influenza, which is the same things to prevent COVID, which is wear a mask, watch distance, and wash your hands. And I will talk about the new CDC recommendations that just came out yesterday. The vaccines are basically, they are different, but they're all set to do the same thing, which is directed to the spike proteins and the immune response that occurs within the patient. That's what the vaccines are. Whether they're mRNA vaccines or DNA vaccines, they're all directed towards the spike protein of the COVID virus. Current vaccine hesitancy, this is the latest I could get, is it's still about 35 to 40% in our country, which means about a third of the patients have significant vaccine hesitancy. We are currently running about 28.9% fully vaccinated, so it's somewhere between 25 and 30%, 35%, and about half of all of our citizens have received at least one injection. Now, to have herd immunity, which everybody talks about, Dr. Fauci talks about it all the time, you need somewhere in the 80s, 85% to have herd immunity. Remember that when we're talking about injections, we're not talking about patients who have had COVID. So if we have a 35% fully vaccinated group, we probably have 50 to 55% of people who are already immune, because you have to factor in the fact that a large proportion of our population either has been asymptomatically infected or unfortunately symptomatically infected. Vaccination is the key. What is it the key to? It's the key to moderate to severe cases. There is no question that vaccination decreases the severity of COVID if you were to get it. It decreases hospitalizations, decreases death, and this is becoming very important. If you don't get infected with COVID, you cannot develop a variant. And if we can prevent the primary infection, we can then prevent the variants. So, and variants are a serious problem. I'll talk a little bit about it. And I think variants are what we're going to be facing in the next 6 months. If we want to get to herd immunity, we need vaccination. And if we're going to return to some form of normality, and I'm not going to define what normality is, we clearly need to have vaccination of our population. And now it's open from anybody over 15 and up. And the preliminary data on the children looks very solid. And within 3 months, we're going to be vaccinating young children. And there is now a study actually going on looking at infants under 1 year of age. And that data will take a little longer to get, but it's very important if we want to return the children to school, the young people to school, the young people are going to have to be vaccinated as well. We're now seeing a marked increase in the number of young people with infections simply because what's happening is a lot of the seniors are not getting infected because they have the vaccine. So we're allowing the ratio to change, and we're seeing about 20% of all infections now are in people of teenage or younger than teenager. The variant strains, there are a whole bunch of variant strains. The one we talk about of the UK, the South African, the Brazil strain, and there's now a New York strain. And they're different. The vaccines have different effects for each variant, and each variant has its own different effects. They have an increased infectious nature. Virtually all the variants are more infectious. Some of them are more virulent. They evade the immune features that we get from the vaccine at times. The vaccine efficacy is being studied for the different variants, and it appears that Astrazeneca, which is not available in this country, but it is available in Europe, the Oxford, from the Oxford trial, does have significant effect for the UK variant. And I really, this is my opinion now, I believe that we're going to need to modify the vaccines, and I have no doubt that we're probably going to need a booster, whether it's in 6 to 12 months from now, with the modified vaccine for the different variant strains. Increasing vaccination results in a decrease in the variants. And we need to control the variant strains if we're going to prevent another surge, which is occurring. If you're following the news in India, it's catastrophic what's happening in India right now with the deaths and the overwhelming of the healthcare system. What vaccines are available? Well, in this country, we have the Moderna vaccine, we have the Pfizer vaccine, we have the J&J vaccine, which is now back being utilized, and we have AstraZeneca, but it's not been approved with an EUA in this particular country. I've actually had the AstraZeneca vaccine. My wife and I were on that trial, and I've also had the Pfizer vaccine. It's a complicated story why I've had both. And I'll talk about them, but so we have two mRNA vaccines, which are Moderna and Pfizer, which are 2 doses, one being 4 weeks apart, one being 3 weeks apart. And you can see the efficacy for routine COVID and for severe COVID. And then we have the J&J vaccine, which is not quite as good. It's single dose, but it's still absolutely efficacious and should be utilized. And I'll talk about the blood clotting. And of course, then we have the AstraZeneca vaccine, which our government has decided as of yesterday to send the 60 million doses we have in reserve to India to help with the crisis that's occurring in that population. Virtually all the vaccines are exceedingly close to 100% death prevention. Not that you can't get infected when you've had a vaccine, but the vaccines themselves are exceedingly close to 100% death prevention. Vaccines in children, we now are doing children greater than 15, which means 16 and up. The data is quite positive. The new data that I've seen is quite positive in younger children. And I believe within 3 months, we'll see an EUA from the FDA for vaccines in young children. We could prevent the transmission of infection. And most important, will allow the children to return back to the school environment. Because especially in certain parts of the country, like where I am, a lot of my patients do not have access to internet, and their children are struggling very much with this homeschooling done on the computer, simply because they don't have the ability to have access the way the other better well-to-do patients' children have. The vaccine fallacies: vaccines do not alter your DNA. They do not alter your RNA. They do not cause a COVID-19 infection. So our patient yesterday, that's exactly the answer she gave me. One of her relatives got the COVID vaccine and developed an infection, and it was due to the vaccine. It is not due to the vaccine. Vaccines do not protect against influenza. And for seniors, it's still critically important that you get your influenza shot. Vaccines do not stop the need for the 3 Ws. Now, it has changed a little bit, and I'll talk about the new CDC recommendations. But you still, if you're in a large group and you're in close quarters, you still should consider the 3 Ws of mask and distance, and then washing your hands. And vaccines will not allow us immediately to return to normal. It's going to be, in my opinion, a fair length of time before we return to normal, but vaccines are the step in helping us return to some form of normality. Pregnant patients, which obviously myself as an obstetrician, gynecologist in maternal fetal medicine, it's critically important. I have been advising my pregnant patients and those considering pregnancy to obtain the vaccine. That a lovely study was just published last week in the New England Journal of Medicine. I actually had seen the study before it was published, and there is no effect on the pregnancy from the vaccine, and absolutely no effect on fertility. And the other thing is, not only does it protect the mother, the babies who are born have immunity to the COVID for a period of time, probably about 3 months. So we're currently recommending the vaccine either during pregnancy or prior to pregnancy. Now, the one thing I do is I tell patients it's probably better to take the vaccine after 11 to 12 weeks gestation. And that's simply an opinion, simply because if the patient miscarries, she's going to blame the vaccine on the miscarriage rate, which the New England Journal of Medicine showed absolutely is not valid. The vaccine do not cause miscarriage. But because most miscarriages will occur early in pregnancy, I have the patient either take it pre-pregnancy or take it after 11 weeks gestation to 12 weeks, which is the end of the first trimester. Which COVID vaccine should you take? Believe me, take whatever you can. Okay. When my wife and I had an opportunity to enroll in Astrazeneca, we took that. And then because the hospital that oversees our free clinic wanted us to take the Pfizer vaccine, I took the Pfizer vaccine too. I have no trouble with that. So, and I would take the J&J, but obviously I've already had 2 vaccines, so I don't think I need another. One of the pearls is if you're going to receive another vaccine, like a flu vaccine, like a herpes zoster vaccine, a Pneumovax vaccine, these are things more in the senior population. Do not do them together. Have an interval of 2 weeks between either the COVID vaccine or the Pneumovax or the herpes zoster vaccine. And believe me, if I have any seniors listening, any of you who have not had the zoster vaccine, please get it. That's an awful disease, and it's predominantly in seniors. And the vaccine is very efficacious, as is the flu vaccine and the Pneumovax for diplococcal pneumonia. So go 2 weeks between vaccines if you're getting another vaccine. If not, just get whatever COVID vaccine you can get. If you've had a previous infection, take the vaccine, okay? Because you can get reinfected. Reinfection rates are rare, but they're most serious in the senior population, which we define at the AMA as greater than 65, which most people use. If you have a current COVID infection, wait approximately 90 days and then receive whatever vaccine you can get your hands on. And I constantly ask, how quickly am I protected if I received 1 shot of the mRNA or 1 shot of the DNA vaccine? You get about an 80% immune response within the first 7 to 13 days, and the remainder up into the high 90s will come by 3 to 4 weeks. So if you've had 1 shot, you have a very good protection after about 1.5 weeks of time from that shot. But it is important that you get the second shot. We are advising not to mix shots. If you have the Moderna, get a second Moderna. Pfizer, get a second Pfizer. But there is a caveat. If the second dose is one of the other vaccines, take it. Although try to get the same vaccine for your second dose, but don't pass on your second dose. Take the second vaccine of the whatever you can get, preferably what you had for the original dose. What are the side effects? There are side effects. Clearly, a substantial majority of patients will have site pain and swelling right around where the injection in the arm goes. A lot of them will have myalgia. That's a flu-like feeling where you just don't feel good. Your muscles are sore. You may run a low-grade fever. You'll have flu-like symptoms. It's most common after the second dose. Severe reactions are extremely rare, extremely rare. There are anaphylactoid type reactions that occur. They have been reported. And that's why when you get the vaccine, they're going to make you wait 10 to 12 minutes before you're actually able to leave the vaccination site because of these extremely rare anaphylactoid reactions. But I have to tell you, I've seen anaphylaxis plenty of times. I've never seen it from the vaccine. And we are now giving it at the free clinic to the underserved and underrepresented population that we deal with here in South Carolina. If you have symptomatology, which is more common after the second dose, and does appear to be slightly more common with the RNA vaccine, it will resolve within 24 to 96 hours. So almost everybody, it resolves in 24 to 48 hours. So the side effects are somewhat similar to the flu vaccine, little more prominent, but by no means are they dangerous and or severe. But plan on, if you get the vaccine, that you may want to take it easy the next day or take the day off from work or teaching or whatever you're doing. There is 1 reported death from receiving the vaccine, but unfortunately, I'm not able to get the data as to what the death was due to. This person did receive the J&J vaccine. It was not the blood clot. I do not know whether the death was related to the vaccine. That's the only death that's reported specifically from the vaccine, except for the blood clots. And I don't even know that that's related. But if you give as many doses of vaccine as being given now, you will see things that happen statistically just because that's what happens in the general population. Now, here is the hot issue about J&J. The syndrome these patients get is called TTS, thrombosis with thrombocytopenia syndrome. It's really called a central sinus thrombosis. I don't want to bore you with this. I've seen about 40 of these over my medical career. They've all been in pregnancy or postpartum. I've never seen one in a man, and I've never seen one in a non-pregnant or a non-postpartum patient. But these have been seen. As of 3 o'clock today, there were 2 new cases. So there are a total of 17 now. And in the new 2 that just happened, 1 was a male. It's the first male who seems to have had this. The other 16 have been females. The vast majority are under 50, and there have been 3 deaths. The big issue with TTS is you don't treat it the way you would treat normal clotting, which is with a blood thinner called heparin, or low molecular weight heparin or something. And so unless people are aware of this, at least one of the deaths was due to a treatment error. The other 2 deaths, I do not know. What's interesting is the vast majority are all women, and they're all relatively young women. And whether this is hormonally related, that research is now being done, because clearly when we see central sinus thrombosis in pregnant patients, it is hormonally related. So this may well be a hormonal issue. I did talk with one of the people at the CDC. As best they know, none of these women were on oral contraceptives. As best they know, none of them were on oral contraceptives, and none of them were pregnant either. So it's about 2 per million doses, and which is the general population rate for TTS, or central sinus thrombosis. But clearly, this was related to the vaccine, but it's exceedingly, exceedingly rare. What are not side effects from the vaccine is shortness of breath, rhinorrhea, which is a runny nose, and loss of taste or smell. If you have these things, you may actually have an active COVID infection, and you need to go to your healthcare provider, to a clinic, whatever, to get tested for that, because you can get the vaccine today and get COVID tomorrow easily. And that can happen. It actually has happened, and it has been reported. So these are the things. If you start to have shortness of breath, you have a significant runny nose, and specifically loss of taste or smell, please go see your healthcare provider. That's not the vaccine. Something else is going on. Here's what fully vaccinated people can do, which predominantly have been seniors, and now it's in the younger population. You can visit with other fully vaccinated people indoors without wearing a mask or physical distancing. My wife's in a bridge club, and all have been vaccinated, so all of the ladies play bridge without any problem. You can visit with unvaccinated people from a single household, your grandchildren, your children, if they're at low risk for severe COVID disease, indoors without wearing a mask or physical distancing. These are people from a single household. If you get exposed, you can refrain from quarantine and testing following a known exposure as long as you're asymptomatic, which is relatively new. And then the newest thing by Dr. Walensky, as of yesterday, is outside mask restrictions have been eased. And every evening, my wife and I walk down by the water, because we're only 2 blocks from the ocean. And we now, even though we do take our masks with us and we put them on when we pass people, only as an example of what people should do, but you don't have to do that anymore. So the outside restrictions have been eased. But if you go to a sporting event, if you go where there's a large group of people to a concert, I strongly advise you to consider wearing a mask, because even if you are vaccinated, you can get infected. There's a misnomer that once you're vaccinated, you never can get infected. Absolutely not true. And this is the real issue that I'm very concerned about. This is what's called long hauler syndrome, or long COVID. And the feds now have a fancy name for it, and they call it PASC, post-acute sequelae of COVID. This is a very, very serious problem that we're just learning about. We are just starting to learn about this. And at the AMA in June, we are doing a webinar specifically on long hauler syndrome with some of the experts in the country. I did ask the AMA, since I'm running that webinar, if they would allow non-AMA members to listen in. They gave me permission to do that. When I have the URL, I will share it with the alumni department. And if you contact them sometime in mid to end May, you can get the URL and you can listen in. It's on June 6th, Sunday, and we're going to have the most up-to-date thing on long haulers, because this is becoming a real problem. We have 6 patients now at the free clinic with long haulers. What is long haulers? It's a whole bunch of things. That's the issue. These people have fever. They have fatigue, very similar to chronic fatigue syndrome, which is a real medical entity. They have myalgias, they have arthralgias, they have headaches. A couple of new things. We're starting to see the onset of diabetes at a much higher rate in long haulers than we would normally see. They have increased cardiovascular problems. They have persistent loss of taste and smell. And there are long haulers now who are 8 months out who are having eating disorders because they can't taste or smell any of their food. And the problem is we don't know what to do about it, and there is no therapy. And then for seniors, the hot issue is brain fog, which some people relate to a form of dementia. It's not Alzheimer's disease, but it's called brain fog. And they act like at times like they have dementia. And the hottest new thing is thyroid dysfunction. And thyroid dysfunction is a real problem for seniors. And that is the newest of the new part of long haulers. And what it does appear that about 1/3 of all people who have a COVID infection, not the vaccine, COVID infection, will develop long hauler syndrome. And there is anecdotal data, that if you have long haulers, take the vaccine, because some people have been improved with the long haulers when they take the vaccine. That is not science. That is anecdotal data. I am advising patients to do that. And there is actually a study going on now looking placebo-controlled whether the vaccine will help with long haulers. But currently, we have no treatment. It's important to find a healthcare provider who believes in you, because these patients are terribly depressed and their suicide rates are 3 to 4-fold the general population, because nobody believes they have everything. They've all been labeled, a lot of them have been labeled as hypochondriacs. So in summary, COVID vaccines are absolutely safe, absolutely safe. You should ask your healthcare provider all the questions you need answered. And if you're uncomfortable with that, and anybody wants to drop me a line, I'm at Lewis B. Weinstein at Hotmail, and drop me a line and I'll do my best to answer any questions. I'm an obsessive compulsive reader. I read at least 2 to 3 hours every day, stuff that's not OB/GYN related. I still want to know as much as I possibly can, but ask the questions you need answered. But the vaccines are safe. My advice, as it has been by Dr. Fauci and other people from the CDC, NIH, and FDA, is take any vaccine you can as soon as you can. And if for those of you that have young children or grandchildren, advise the children, especially if they're greater than 15, to get the vaccine. It will help them, and we'll use the vaccine in the younger children within the next few months. We need to prevent long hauler syndrome. You won't believe how serious of a problem this is until you get to meet somebody who has this. And then this is my own opinion. A lot of us have changed our lifestyle because of COVID. My wife and I do different things. We walk every night. We're not going to theater, which we love. We eat out all the time, but we bring home. We don't eat in. We haven't eaten in a year and a half. But I just brought home food tonight. And we're doing a lot of things that we adopted during COVID. We're going to keep them up. So look at the things you did in the last 12 to 15 months. Some of them may have been pretty good and may have been good for you and your lifestyle. And if so, think about keeping them up. Post-vaccination, maintain the 3 Ws. When we're around vaccinated people and everything, I'm around my tennis colleagues who've all been vaccinated. I don't wear a mask, but walking to the courts, I do. And my opinion is that we're going to go from a pandemic, hopefully not another surge, into an endemic, which means basically this will be like flu. And I think that we will be receiving booster shots for the COVID vaccine, either 6 months, 12 months, 18 months. I'm not smart enough to know. What we do know is that the immunity from the vaccine lasts a minimum of 6 months, some data that it lasts 9 months, but we don't have any data much data beyond that. So the answer is, how long will the vaccine last? Like a rubella vaccine, German measles, that will last your whole life. Chickenpox vaccine lasts your whole life. But flu vaccine, you do every year. I personally think that the COVID vaccine will be an endemic issue. Hopefully we won't see another surge, but look at what's going on across the world, especially in India. And remember that we have to prevent those things from happening. Take whatever vaccine you can get, prevent long haulers, and think about some of the lifestyle issues that you've changed. So that's what I wanted to share with you. And I want to make things real simple. I mean, you can bring your life down into just very simple into 4 bottles. And this is the 4 bottles of life. You can see the little one, the middle one, the mid one, and then the final one. And God knows a lot of us are between 3 and 4. So that's what I wanted to share with you. I'll be glad. I'll turn it back to Dr. Williams. I'll be glad to answer any questions that I can. And she is also, Dr. Williams is superb, has her PhD, and she can talk about some of the laboratory science where I am more of a clinician scientist. Dr. Williams?
Great. Thank you so much. So I was fortunate enough to be able to look at all the pre-submitted questions, and some of them dovetail and synergize with some of those in the Q&A. So I'm going to start here. So you talked about folks being able to get COVID-19. We call those breakthrough infections. So someone's wondering if vaccinated people can still contract it. Can't they give it to others? So shouldn't we still wear masks with other vaccinated people outdoors, indoors? What's your thoughts on that?
There is some data that suggests that you can be what's called an asymptomatic shedder, which is a person who doesn't even know they have it. We do think that if you're in with unvaccinated people and you are shedding, you can infect those people. If you're in with vaccinated people, it's exceedingly likely. Breakthrough infections are very rare. They do happen. There's no question they do happen, but they're very, very uncommon. And so if you're in with vaccinated people, the mask is not necessary. If you're in a large group or with a large group of unvaccinated people, for example, the Indy 500 just announced they're going to have 130,000 people in the stands. One is I wouldn't go, but if you do go, I'd strongly advise you wear a mask because you can get reinfected. It appears if you do, it won't be severe, but the big issue is, could you get long haulers? And if you're a senior and you're a woman, one of the things I didn't say, 75% of long haulers are women. We don't know why that is. And the majority are young women, which is fascinating. When I was talking to the people on this AMA panel we're going to do, the majority of the patients they're seeing are women between 30 and 55. And the big question is it somehow hormonally related to either estrogen, progesterone, something like that? Those studies are now being done, but you clearly don't want long haulers, Dr. Williams. And so it's still prudent to wear a mask unless you're sure you're in with people you know especially indoors. Outdoors, you can almost get away with anything unless you're in a large group.
Great. So can you speak to how the FDA emergency approval differs from the FDA full approval, and how much risk is implied by that difference?
Right. I for full disclosure, I was on the OBGYN FDA panel that looked at therapies for preterm labor. So I am no longer on the FDA panels. All right. But I know how it works because I spent time in Maryland. Emergency use EUA, which is emergency use authorization. They have a separate committee that is not part of the FDA that reviews all the data. That committee then makes a recommendation to the FDA, and then the FDA decides whether to accept that recommendation or not. I would say in my experience, about 80 to 85% of the time, the FDA will accept that recommendation. But about 10 to 15% of the time they won't. Now, in an EUA, what it means, it hasn't gone through the full process of all the FDA committees, but the outside committee has recommended it to the FDA, and the senior people of the FDA have allowed it to have EUA, emergency use authorization, but it's still, we will see in the next 6 months, full authorization for Moderna, for Pfizer, because they have requested it. It just hasn't happened yet. The FDA is a real bureaucracy. It's a huge building in Maryland with God knows how many hundreds of people there. They do a spectacular job. They're all clear scientists. A lot of them are not practitioners. So that's why when they have a panel, they have a panel of practitioners. When I was on it, and for the EUA for these, they had virologists, epidemiologists who were not FDA employees. So they were not wedded to the FDA. So I am very comfortable with EUA. We have seen that before with cancer chemotherapeutic drugs, where they get an EUA to use the drug, or a compassionate use authorization, and then eventually it's approved by the FDA later on. The reason they did it for this is simply because they didn't want to waste time. We needed to do it because we were having, we've had now, more people that have expired from COVID than actually died during the Civil War. So, I mean, that's how serious of a problem it's been in this country and throughout the world. Now, this is not equivalent to the flu epidemic of 1918, which is called Spanish flu, but it has nothing to do with Spain. So it's not Spanish flu, or the Black Plague back in the 14th and 15th centuries. That's when about a third to half of the world died. So, but this is just as catastrophic what's happened. So EUA, I'm very comfortable as a practitioner, having been with the FDA, that EUA is perfectly respected and safe, and eventually it'll be fully approved.
Great, thank you. So if a person has had one dose of the vaccine and then contracts COVID-19, either in the 3 or 4 weeks intervening, what are they saying about the follow-up second dose? How long should they wait?
It's a very rare circumstance, and there are only a few reports of that. And almost always what's happened is when they look back, the person actually developed the infection pre the vaccination. In other words, they were infected today, didn't know it, got the vaccine tomorrow, and then developed the infection, 6-7 days out, because they would have had immunity by 8 to 10 days in the 80% range. If they have an active infection, the current recommendation is to get whatever proper treatment you need for the active infection, and then wait your 90 days. And then the question is, do you take 1 dose or 2 doses? Nobody knows that. What I would recommend, my opinion, is I would start from scratch and take 2 doses. But that's my opinion. Nobody really knows whether you can just take 1 shot back out in 90 days. And if you're going to get the J&J, then that's all you need anyways, would be the 1 shot 90 days out. But any active infection, you should wait 90 days.
Great. And this is a question I've been getting from folks. If you don't have any side effects following your second vaccine, is there any indication you're not developing immunity?
No, that's a great question. And neither my wife or I had no effects from the Astrazeneca vaccine. And that's why when the hospital called us at the free clinic to get the known vaccine, AstraZeneca wouldn't break the code. So I didn't know what I had. I just assumed I had the placebo. So I went and got the real vaccine. I called AstraZeneca to remove myself from the trial, and they broke the code and said, oh, you've had the real vaccine. And we only have a handful of people in the country that have had mRNA and DNA vaccines. So please stay in the study. So if you've had no side effects, it doesn't mean that you're not protected. And if you had a lot of side effects, it doesn't mean you have super protection. It sounds good and it's nice, but that logic just doesn't fly.
Are there any conditions like autoimmune diseases that would result in a person not developing immunity or protection following?
Absolutely. And this is where you really need to get to talk with your physician. For example, if you have lupus, and I see a lot of women with lupus, a lot of pregnant patients with lupus, and you have lupus nephritis, which is a renal disease, and you're on high-dose steroids, which is prednisone, your immune system is blocked, and you really need to talk to your healthcare provider, because the little bit of data we have shows a very poor immune response to the vaccine. If you have psoriasis, you can't take the vaccine unless you're on high-dose immunosuppressive therapy. If you're on cancer chemotherapy, you really need to talk to your healthcare provider. Especially, I see a lot of patients with breast cancer, obviously, and they're on different kinds of chemotherapy. But if you're on a drug like tamoxifen or anastrozole, which the ladies with breast cancer are on for 5 to 10 years, that doesn't affect your immunity. So you should take the vaccine. But if you're on a regimen of chemotherapy, where you're getting injections once a week, once a month, whatsoever, or men with prostate cancer, you really need to talk to your healthcare provider, because some of these, it won't work. It's not that it will harm you. There's no data that it will harm you, but it will not work. So you really need to keep the 3 W's up.
Great. In breakthrough infections, have there been any increased risk of what we would call cytokine storms? And if you want to describe what those are to our audience, that would be great.
Yeah, a cytokine storm is where you get desperately ill with very high fevers. We see that with different diseases, not just this. You see it. You see something very similar when you treat a patient for syphilis, which I've had to do a bunch of times, and you'll see something very similar to that. But it's not something you want to see. You're desperately ill. Your risk of death is not as great as you think it is because you swear you're going to die. If you're in a cytokine storm, you are really, really ill. But if somebody knows what they're doing, the therapies are reasonable, quite good, and the fever needs to be treated because it can be quite high. But the reinfection does not appear to have any greater incidence of anything else than any other infection and tends to be more mild, but also is more common in the seniors. So it's more common in seniors, tends to be mild, but the big worry is they can develop long haulers. And I can't stress to you how important it is to prevent long haulers. The way you prevent long haulers is not get COVID. If you don't get COVID, you can't get long haulers.
Great. Does Capoxone, which is used for MS, affect the vaccine effectiveness?
I would have to tell you that if I had to pay, I'd have to go and check the literature.
Okay.
Dr. Williams, I currently don't have any MS patients. I have had pregnant patients. I've not had them on that drug. I'd have to read about it. And so the answer is, I don't know, but I would clearly talk to your neurologist, who is probably the physician who's prescribing it.
Great.
MS patients can have a lot of pulmonary issues. So clearly I don't want them to have COVID, but I don't know if the vaccine is efficacious with that particular agent.
Great. What is the likelihood of long-term side effects from these vaccines?
Long-term, the longest term we have now is about a year. I had my original AstraZeneca in December a year ago. So I'm about a year and a third out. And that's about the longest data we have because none of this existed much before December. People were in the Moderna trial in November, December. That's when all these trials started. And so the answer is we haven't seen any yet. And my guess is, having been around vaccines my whole career, having administered Tdap to hundreds and thousands of pregnant women, Tdap is for tetanus and pertussis, et cetera, I honestly think there'll be minimal to none. I have to say it's as close to zero as you can get. And in medicine, you learn never say never, because sooner or later, something's going to happen. But I would say it's as close to zero as you can possibly get, the long-term effects. So I think we'll have that data in another year or two, but I wouldn't wait that long to get a vaccine.
Yeah, and we hosted Dr. Monsif Slawi, who headed up he was the chief scientific advisor for Warp Speed. And one of the things that he talked about for COVID Cafe was that 85 to 90% of all side effects for vaccines, for all vaccines that have ever been created, happen within 90 days.
Absolutely.
So they were pretty, they went out double that before the EUA, but they were pretty clear in the data about when the majority of side effects happened.
Correct. And that was some of the older folks will remember back in the 70s, there was a flu vaccine that ended up with Guillain-Barré, and having seen 3 patients with Guillain-Barré, but that occurred fairly soon after the flu vaccine. And I don't remember what strain it was then. That's too many years ago for me. But there hasn't been another. There have been several reports of Guillain-Barré from the vaccines, but it's within the normal statistics of patients. If you have 1 million patients, somebody's going to get Guillain-Barré. It's just going to happen. And so there's been no increased risk of anything other than the blood clotting of the central sinus thrombosis, or the cerebral blood clotting, which is very, very rare, very dangerous. It's not to be taken lightly, but probably in the range of two per million, and which is much more common in pregnancy. So because that's the ones I've seen over my career.
Great. I've also gotten this question and thought about this when I got my second shot and I got flu-like symptoms. Is it recommended you take NSAIDs or aspirin after that vaccine? Is acetaminophen okay? Ice, heat?
Yeah. All right. Now I'm going to give you my opinion. Okay. So you know. First of all, there are a lot of people who have flu-like symptoms, as you did, Dr. Williams, in the
Yep.
intervening day or two afterwards. And in all honesty, Tylenol doesn't do anything. But if you take it for a day, it work. So what I would tell you is this, okay? The current recommendation of the CDC is to stay away from non-steroidals. And some people call it Motrin. It's really ibuprofen. If you can avoid it for the first 24 hours, do avoid it. If your life is so miserable that you can't, take it, okay? And I have no qualms about advising my patients, if they're really miserable in that 24-hour time period after the vaccine, to consider taking a non-steroidal. I wouldn't take aspirin, and there are some unique reasons why I would stay away from aspirin, because of the clotting issues, because of Rye syndrome in children. There's just a lot of reasons. Tylenol is great, or acetaminophen, but it doesn't do much, unless you have a high fever. But in all honesty, if you're really having problems and it's been more than 24 hours, I have no problem advising a non-steroidal. Theoretically, this is what the CDC says, it may block the immune response, but they have no data to support that, none whatsoever. So I'm comfortable. I don't like to see patients suffer. So if you're suffering after 24 hours, I would take some ibuprofen or any other non-steroidal you can get your hands on.
Great. One of our audience members wrote in early about the difference in the dosage of the two mRNA vaccines. And I'm not sure you know this, but why is Pfizer a 30 microgram dose and Moderna a 100 microgram dose? And why do they have different days in between the time in which you get your first and second dose?
I am not enough of a basic scientist to answer that question. They are somewhat similar, but they are not exactly the same. It's using an mRNA. This is not new technology. That's important for the audience to appreciate. mRNA technology has been around for a long time, and we're using that in cancer chemotherapy. It just happens that you can do things a heck of a lot faster with mRNA than you can do with the adenovirus DNA, which is what AstraZeneca and Pfizer are using. Why they have different dosages, and why one's 3 weeks and 4 weeks, I don't know that. What I do know is that those are not in stone. You can eat if you're more than 3 weeks from one and you're within 4 weeks, just take it. Those are sometimes in medicine we do some arbitrary things. Somebody picks a number, and I'm not sure how much science there is behind those numbers. But I really can't answer any further beyond that.
Great. Do you know if there are any variants showing resistance to the vaccines yet?
So far, we haven't. We know that the vaccine for some of the variants is not as effective as for other variants. And we know that when the studies were done, some of the studies were done before the variants presented themselves, and J&J was done after, when the South African variant was around. And so some of the different efficacies may be due to the variants. But so far, the majority of the vaccines are reasonably effective against the variants. But right now, both Moderna and Pfizer are working on modifications for some of the new variants, like the Brazilian variant. And there's a new one they just identified in India, and I don't know what the name of it is.
Oh, the double variant, yeah.
And as you know, the catastrophe that's occurring in India with hundreds of thousands of cases per day. Now, they did let up their mask wearing, and they had some massive rallies in Mumbai and some of the other cities. So I think, unfortunately, they're paying the price for easing the restrictions on the 3Ws. And it's terrible because they don't have the respirators and the oxygen and all the medical care that we have. And that's why we are sending supplies over, according to what I was told from the CDC.
Great. If someone feels sick on the day they're scheduled to get vaccinated, do you think they should get tested?
That's a tough one. It really, what I would want to do is, I'm old fashioned. I like to talk to people and see. I want to see what's bothering them. I mean, if they're having a stomach flu with some stomach issues or gastrointestinal issues, I would have no problem with it. If they're having a flu-like illness, the answer is yes. I would probably advise them to be tested. But I would need to talk to them to see what's bothering them. And then I would make a decision based on the best clinical information that I can. There's no harm in being tested, but do remember there are both false positives and false negatives from both the antibody testing, and once you've had the vaccine, you don't need the antibody test, and from the antigen test. So you can have, as did the governor of Ohio, he was positive, and 3 hours later he was negative, and then they do the third one to see what the hell, let's take 2 out of 3. So you got to remember false positives and false negatives.
So we had talked about this in our practice session. So I'm 38, and I've been hearing from friends about anecdotal menstrual or lymph node side effects in my female friends, especially with the Moderna vaccine. What are you hearing about that?
There's a lot of stuff on the internet, along with the fertility issues, which really affects the Gen Ys and Gen Zs, who are very concerned about this. And there is absolutely no science whatsoever to support those claims of menstrual irregularities and or infertility. Now, menstrual irregularities do occur as one ages because of the ovarian axis failure that occurs in the mid to late 30s, early 40s, which is why infertility dramatically increases as one gets over age of 38 or difficulty becoming pregnant. But there is absolutely no data to support menstrual irregularities with either Moderna or any of the other vaccines, other than the fact that if you give it to enough women and the women are in their late 30s, early 40s, some of them will be perimenopausal and will have menstrual irregularities, because bleeding issues in the perimenopausal patient is exceedingly common. I mean, I see that every week in the clinic. But it's not a reason not to take the vaccine. And then the other thing is, when you're talking to your friends, you'll hear me, I never say about a shot. There is very good data that shows people are very uncomfortable with shots. So I always talk about administering the vaccine. I try not to use the word injection. There are times when I will, but I never use the word shot. And I really don't like when the news people are using, take your shot or get the jab. Or today we're going to show the president of the United States getting a jab. There are a lot of people who are, first of all, the needle is tiny and it really doesn't hurt. But there are people who have needle phobia. I appreciate that. So I never give anybody a shot, but I will administer the vaccine. And sometimes I will say, I'm going to give you an injection now. I don't say a bee sting, because that's what a lot of doctors do. And a lot of patients are really afraid of bee stings. So I'll never say, oh, you're going to get, it's just a small little bee sting. I never use that either.
Can you speak to how the Novavax vaccine is made? Have you read up on that yet?
I don't want to get into the new vaccines. There are almost 100 new vaccines that are being in trial right now, including several oral vaccines. And there is one company that's going to release their data on May 3rd or 4th on the phase 2 trials of an oral vaccine, which is in a liquid form, like you give a polio vaccine to children. But I don't want to get into anything that is still investigational, simply because that is not my area of expertise. And those things can change because they only share, the companies share only what they want to share. And so I never really know, I'll know what I'm reading if it's in a peer-reviewed journal. That's why I put up that pregnant patient stuff from the New England Journal. That's peer-reviewed. That's legitimate stuff. But I don't go to company websites. I just don't do that because I don't know what the biases are. And I'm very, not that they're lying, but I'm just uncomfortable with biases.
Can you speak to surface transmission?
Yes, that what we call fomites. I know it sounds strange, but a hard surface or a book or something is fomites. And there are people, and I understand why they have the fear of this, but in some people it's become pathologic. It's very hard to contact COVID unless somebody coughed on a book and within a short period of time, you rubbed the book and then rubbed your nose or rubbed your face. Okay, so there's a lot of things that have to happen. But the fact is, it's exceedingly uncommon to have transmission from a hard surface. And I know everybody get into wipes and, wiping everything down, wiping your mail, wiping this, wiping that, wiping the newspaper. Maybe we should wipe out newspapers, but you don't need to wipe them from COVID. So the answer is, could it happen? Again, in medicine, anything can happen, but it's so exceedingly uncommon that unless somebody with direct illness has come in contact with that, then you come in contact with that surface, and then you put it close to your face, your eyes, your mouth, your nose, okay? Not just rubbing on your skin. It's got to go to a mucosal surface of eyes, nose, mouth. There's virtually no risk. So I wouldn't worry about going to the store and buying, groceries or whatever, picking up the container, whatever. It's just, it's a little bit overkill.
So one of our attendees heard from an anti-vaxxer that the Pfizer or Moderna mRNA vaccines can change your likelihood of autoimmune diseases. Is that true?
Absolutely not true. I mean, it's sort of the scary thing is when I'm seeing the young women in the clinic, now that we're giving the vaccine out, I mean, they bring up the infertility issue, and it's the same stuff. People can put anything they want on the internet, absolutely anything they want. And the answer is it's not true at all. Okay. The vaccine, the benefits of the vaccine so outweigh the risks. Not that you can't have a side effect, not that you can't have a blood clot with J&J, but the risk benefit ratio so favors the benefits. It's not even in the same ballpark. So totally different issues. And again, I can't stress how we need to prevent long haulers. Any of us who have seen it, it's a terrible, debilitating disease that we don't even know how long it's going to last.
Great. Well, that was it for my questions. I really want to thank you and all of our attendees for the time today, this evening. And thanks to Bates for hosting us. And I hope everyone continues to wear a mask, wash their hands, and distance when possible. I've been saying that since March. Lou and I, you can find my contact information on the Bates website. Happy to field any questions. And as Lou said, he is as well. And I hope everyone stays healthy and safe as we go into the summer. Thanks, everyone. Have a great night.